and I was diagnosed with metastatic breast cancer July the 1st. So I'm really very newly diagnosed. In the middle of chemo, carboplatin and Gemzar. This is round 3, 9th day. So I'm standing, but thank you. This is the breakout session for the newly diagnosed on understanding metastatic breast cancer. Before I introduce our speaker, please remember to use the index cards in your folder to write down any questions that you might have. There will be a Q&A session immediately following the talk. Anna Kate Owens is a nurse practitioner in the breast cancer in the Division of Medical Oncology. She received her MSN degree from UNC, Chapel Hill, and her BSN degree from the University of Alabama at Tuscaloosa. Her clinical interests include medical treatment for breast cancer and breast cancer survivorship. Please join me in welcoming our speaker, Anna Kate Owens.
Thank you so much. Here, let me see if I can get that. There we go. It's an honor to be here. I recognize some familiar faces, and just wanted to give you guys a very basic overview of metastatic breast cancer. Some of you won't learn anything new, but that's okay. Just to kind of walk through some of the basics about metastatic breast cancer, and I wanted to give us plenty of time for questions. I don't do a lot of public speaking. I spend most of my time in the clinic one-on-one with patients, so I'm glad we're a small group, and we'll keep it really informal and just kind of walk through it together. So that was such a nice introduction. My own introduction was going to be that this is my part-time job. This is where I spend 3 days a week with some of the best people on earth, but I also have a full-time job. It includes a night shift. And very joyously, this is my part-time job. This is Grace. This was taken yesterday. So as she's in her pre-crawling state, about to crawl all over creation. All right. So what is metastatic breast cancer? It is usually recurrent, but it can also be new. So you might be diagnosed with metastatic breast cancer as your first diagnosis. About 30% of people who have an early breast cancer will have a recurrence. It means that it's spread beyond the breast, or it's distant. You hear that word a lot, and it's chronic. We're going to talk more about these things. So, recurrent disease. 30% of people who have an early stage breast cancer will have a recurrence, even when you do all the right treatments. So even if you get the state-of-the-art 2014 standard of care, still 30% of people will have a recurrence. And that's important to realize. Sometimes, though, it's diagnosed in somebody who didn't have breast cancer before. So what we call that is presenting stage 4, presenting metastatic. How does it happen? Cancer cells that start in the breast tissue break away from the primary tumor, move through the bloodstream or the lymph channels. They find a new home somewhere else in the body. They set up residence, and that's where they live. They don't become. They're not then called the name of the new place they live. They're still called breast cancer. So it's called metastatic breast cancer to the lung or to the bone or wherever it is. This is just a graphic. This is an ASCO graphic that shows you the idea of what metastatic breast cancer is. So it can still involve the breast and regional nodes, so those would be the ones in the chest, but in a distant site away from those two places. So anything outside the breast, the regional nodes, which would be the ones in the chest, the clavicle on that side, or the underarm, anything outside of here is considered metastatic for breast cancer. So what are the most common sites? The chest is common. Your chest, your breast, where the breast used to be. The lymph nodes are a common site of recurrence. Bones are common. Lungs are the lining around the lungs, which is called the pleura, your liver and brain. Sometimes, and usually, it's the place that the cancer is that causes the symptom. So if it's in your lung, you may cough. Or have shortness of breath. If it's in a bone, then you may have pain in that spot. And sometimes it's those symptoms that leads you to this diagnosis and leads your team to discover this. Different subtypes of breast cancer may be more likely to come back in different parts of the body. So breast cancers that are hormone receptor positive tend to like to come back in the bones. Triple negative breast cancers tend to like to come back in what we call the visceral organs, so lungs, brain. Biopsy. So are you going to have a biopsy? If it's a recurrence and the place that it's metastatic to is easy to access, often people will have a biopsy because about up to 20% of breast cancers will change, I call it changing their stripes. You may have different receptors when it comes back than when it originally was there. Particularly if we think the receptors might open up new treatment avenues, then we like to get a biopsy to get the receptors on the distant site of disease so that we can, open up as many treatment options as we can. Sometimes it's not an easy place to access. So sometimes the biopsy is too risky medically. So we're talking about usually needle biopsies. Like what comes to mind are lung biopsies are kind of difficult. Sometimes we do them with the help of a thoracic surgeon, but they can be difficult. I'm loving the dog. I wish she could come up here. But if the site is easy to access, then biopsies are pretty common. If you are presenting metastatic or presenting stage 4, then the biopsy is almost the rule because that helps establish the diagnosis. And again, when you're biopsying a distant site, you still see the features of breast cancer cells. So a pathologist can look under the microscope and tell you, even if it's a sample from a liver or a bone or somewhere far away from the breast, that these look like breast cancer cells. Which can be helpful because sometimes people have had more than one malignancy in their life. And we have to know which thing we're dealing with now. So like I said, typically we're talking about a needle biopsy performed under imaging guidance. So that probably is the most common. I don't know if I have a picture of that, no. But these are very well tolerated when done easily. Sometimes the idea is kind of frightening, but people actually tell me that the idea of it was worse than the actual procedure and they get through it fine. The other reason that you might have a biopsy that we'll be probably seeing more in the future is trials like at UNC. We have something called UNC Seek, where they take the tumor and look at the gene mutations of the tumor itself to try to help determine what treatments we should use. And that will probably become more standard as scientists get better about it. So that's another reason to have a biopsy. So what is metastatic breast cancer? It's chronic, so it's a chronic illness. Once it's outside the breast, it's something that you have, not unlike diabetes or hypertension. Once you have it, you will always take high blood pressure medicine for the rest of your life. I realize it's not high blood pressure, but it is a way to think about it as a new chronic illness. It can be difficult to remove, so typically, not always, but typically these sites are in places that we can't take out with surgery. So we control the disease with medicines. So it usually requires ongoing treatment in order to do that, of one form or the other. So what are the treatment options? Systemic therapy, so medical therapy, pills, anti-estrogens, IV medicines like chemo or HER2-targeted medicines, medicines on a clinical trial would be systemic therapy, things that go all over the whole body and treat cancer no matter where it is. Radiation sometimes, or I should say radiation often, maybe. Surgery less often in breast cancer. Unless it's the only site of disease. So sometimes we're in a unique position where there is one distant site and is the only thing, and sometimes then a surgeon will remove it, so that then we have none. We know it's still there as a systemic illness, but we have essentially removed the biggest bulk of it. So that's the one instance where sometimes surgery is used. So thinking about systemic therapy, how do you choose the treatment? The breast cancer subtype determines the treatment. So cancers that are hormonally sensitive, we tend to lead with hormonal agents, so tamoxifen, aromatase inhibitors, anything that manipulates the estrogen and progesterone in our bodies. Cancers that are HER2-driven, the therapy is tailored to that and uses HER2-targeted therapies. And then triple-negative breast cancers, we use chemotherapy as the mainstay of therapy. The goal of treatment is different. So the way I think about it is, when you're having your adjuvant therapy, meaning, if you're diagnosed with an early stage breast cancer and you get your adjuvant treatment, that's a sprint. That's like pound it hard. You only have a short way to go. The goals shift when you're in a situation where you're treating metastatic disease, because we want there to be long periods of treatment, and we don't want it to be so strong that you can't tolerate a really long period. We want each therapy we want to ride it out as long as we can. So I like the image of the runner, because you think about pace, and that kind of mindset of preparing yourself for a pace. It's kind of a nice image to put in your mind. And I think more so the patient is part of the decision-making team. You're always part of the decision-making team, but when you have metastatic disease and the goals are shifting, your vote and your life become more central to the decisions and the discussion. So this is just a slide sort of to illustrate how we think of the subtypes of breast cancer in the clinic, being hormonally sensitive, being HER2-driven. HER2-driven tumors might also be hormonally sensitive, so those two things overlap. And then triple-negative, which is not expressing hormones or this protein called HER2. So this is just a slide that outlines some of the systemic therapies for each subtype. As I mentioned before, hormone receptor positive cancers, we tend to lead with all of the agents that manipulate the hormones. If that cancer also overexpresses HER2, then we'll add this column to this column. Sometimes we'll use chemotherapy, not in combination with the anti-estrogen treatments, but you still use chemotherapy to treat hormonally sensitive tumors, but usually after you've been through this list. HER2 positive breast cancers, these are some of the medicines that we use to target. Often these are combined with these, and sometimes these are combined with these. These are the great drugs that can be combined anywhere. And then triple-negative tumors, like we talked about, chemotherapy are the mainstays of therapy for triple-negative tumors. Bone-directed therapies, these are things that probably some of you are receiving. When you have cancer in a bone, it can weaken that part of the bone. It can cause pain and make it more susceptible to have a bone break. So we use therapy. I almost said medicines, but then I remembered I put radiation on the list. We use therapy to help strengthen that part of the bone and reduce pain and reduce fractures. So probably the one that most people will be familiar with is Zometa because it's been around the longest. It's an IV medicine. You take it once a month. It's typically pretty well tolerated. Some people will have kind of a flu-like reaction, particularly the first time. Denosumab is a newer agent. It's an injection which you receive in the clinic, which is nice because then if you're... That's Xgeva. Yeah, because I was trying not to use brand names.
I was curious.
Yes,
About that.
denosumab is Xgeva, and that's probably what people call it because it's a lot easier to say. That's an injection you receive in the clinic, and it makes it a little easier. So if you're not already going to the infusion room for chemo, then you can avoid the infusion room. It's also given once a month. Both of those medications carry a slight risk for something called osteonecrosis of the jaw, so that's something to talk about with your team, particularly if you have a lot of dental issues. It's rare, but it doesn't happen never, so you have to think about it. And then radiation. I think of radiation as like spot welding. It's like a flashlight. It works where you point it. You can't point it all over your body, but you can point it in certain spots, and it can be very helpful to strengthen a part of the bone, reduce some of the pain associated with a bone metastasis. What about clinical trials? Of course, I work at UNC where there are lots of clinical trials, so I'm pro-clinical trial. But it does increase the number of treatment options that you have. So that slide, 2 slides ago, these are all standard therapies. Anybody can have these anywhere. In a trial, often you're getting something that's not part of that list. So if you think of all the treatment options as being in a bucket, when you're in a trial, you're just putting one more thing in your bucket of options. And typically, trials reflect the most current thinking. So, trialists are designing things that they think are going to be the best new thing. And so hopefully then that is what plays out. What are the downsides? And there are some. It typically requires more time. Maybe it requires travel to a center that isn't, right at your doorstep. So it might not be the best option for all the time. Maybe it's not the best thing now. Maybe you need to be close to home now, or, your life plays into this as well. I think about parents who have kids home for the summer, things like that. So you kind of think about the pros and cons. And then sometimes there are unexpected side effects when you're on a trial, particularly when you're in a trial with a brand new drug that hasn't been given to many people. So that's always something that you want to talk to your team about. What are the side effects? And then know that sometimes there will be side effects that we didn't anticipate. And I think when you're in a trial and when you're taking care of patients that are in a trial, keeping an open mind is the key, because everybody is different. Every individual will experience these new medications in a different way. Still being said, I still think, when trials are available, they're often a great option for people. So we talked a little bit about radiation to treat bone metastasis. When you have brain mets, radiation is a mainstay of therapy. So it's either used to treat the whole brain, like when there are lesions throughout the brain, or sometimes very focused, what is called cyberknife or stereotactic radiosurgery. So you think of like a little, almost like this laser pointer, tiny little beam of radiation, just pointing radiation where it needs to go. Sometimes when a person has breast cancer that's in the breast and somewhere else in their body, and we don't want to do a mastectomy, or we don't want to do breast surgery because we don't want to go through surgery, sometimes we'll do radiation on the breast just to palliate that tumor, to make sure it's not causing pain or getting bigger. Radiation is not usually used to treat your viscera because it can cause too much damage, although sometimes they'll use it in a focused way. So again, kind of like we think about with the pinpoint radiation in the brain. There are some techniques that are used sometimes in metastatic breast cancer. And again, it goes back to if there's only one site of disease, then sometimes those things are employed. So if that applies to you, then it is at least worth a conversation with your treatment team about whether that's a feasible thing for you. Surgery is not often used in metastatic breast cancer, not because we don't like surgeons, but because systemic therapy works better. So if it's a systemic disease, it's a chronic illness, we think of it as kind of being a systemic illness. When you do surgery, you're really focusing on one part of the body and not on the rest. So often it's not used, but these are a couple of places like brain tumors, or sometimes to remove a breast tumor that's bothersome to a patient, then we'll use surgery. All right, so what are the goals? You're trying to control the cancer, reduce the symptoms of the cancer, maybe prevent new symptoms, and maximize quality of life. So when we say control the cancer, what does that mean? So you get therapy X for 3 months, and then you get a follow-up scan, CAT scan, bone scan, PET scan, whatever you and your team are following. And everything stays exactly the same. Is that success? It is. We think of that as quite successful because we know that if we weren't using therapy, we would see growth. We might see new spots. So even if you're stabilizing the cancer, that is success. Sometimes that's hard to wrap your mind around because you want to see it, all of us want to see it shrink away into nothingness. But even if you stabilize it, it's still successful. And then you're preventing new sites of disease. So controlling, when we talk about controlling the cancer, that's what we're thinking of. Maximizing quality of life. Reduce the symptoms. So reduce cough. I think of that as, a presenting complaint that people have when they have metastasis in the lung. Often when we give chemo or their first-line therapy, it's quite satisfying to see that cough whittle away into nothing. Or pain, belly pain or bone pain will often minimize when we start therapy. And then you don't want your treatment to be worse than the symptoms of the cancer, right? So you don't want to start with one problem that the cancer caused and then get rid of that problem, but then you have 10 new problems because of your treatment. So it's a very balanced decision, and it's often an art and a process, right? So you start with something and you kind of see how it goes, and then there's often a lot of adjusting because you want the therapy to be sort of minimally bothersome in order to achieve the goals. And this is my mother-in-law, by the way. Isn't she pretty? All right. So how can you help? Like, what is your job here? And I was glad that Dawn kind of talked about this in the last session. I think your job as a patient is to communicate well, if you can, and be honest. Like we were just talking about. How is it going? How is the cancer affecting you? How's the treatment affecting you? If you don't want to be honest anywhere else, be honest in your visits. Sometimes it's hard because, if you can keep a mental wall around you, like it's not bothering me as long as I don't think it is. And that's okay, except with your team, you really gotta lay it out. Because your team needs to know, is the therapy worse than where you started? How is this really impacting your daily life? And I think if all of us could go home with you for a day, we would know a lot better, but we have to rely on you to tell us. So I think that's key. That's how you can help. And then be honest with yourself. Find at least one person that you can be straight with, a friend, a family member, a clergy person. And I don't say that lightly, but I think it's really key and part of your sense of feeling genuine through this process. Common early experiences. We'll just talk a little bit about this because I think there's so many wonderful speakers this weekend that are going to cover these things. But what's common in the early days? People naturally were questioning, what's my treatment? What kind of time are we looking at? How do I tell other people? How do I get support for myself? How do I get support for my family? And then what does that mean for my life and my lifestyle? So questions about treatment. What's the next step? The next step is different for everyone, but that's common, right? So you're talking with your treatment team. How will you know if your treatment is working? Usually, so our practice is typically 2 or 3 months pass after we start a new treatment, and we'll do whatever scan it was that we started with. And there's not one that's magical better than another one for every single person, but maybe it's a repeat MRI of the brain, maybe it's a repeat CAT scan of your chest, maybe it's a whole body PET scan, PET CT. And how long will you take treatment? So that's also different for everybody, but in general you can think about it that you'll take treatment, or at any given treatment, for as long as it's working and as long as it's not bothering you and as long as you decide you want to. Right? So if a treatment is working, it's stabilizing the cancer, it's not bothering you, meaning it's not causing side effects that are impacting your quality of life, and it's still what you decide you want to do, then you keep going. Anytime one of those things falls out, so it's not controlling the cancer, then you switch to something that hopefully will. If it's controlling the cancer but the cost is too high, then you need to shift gears, either to something different or you need to dial down what you're doing. Maybe it's time for a break. We do that. We call it therapy holiday, chemo holiday. All of those things play into how long you will take any given treatment. Common experiences. I'm not an expert at this. I have many patients that have talked to me over the years that I've been at UNC, what it's like to tell your spouse, your partner, your children. And then this is kind of a big one, is what do you share with your larger community? How do you share that? Do you tell people at work? Do you tell people at church? Do you tell people, who do you tell and where do you draw the line? Do you tell everyone? Do you just tell a few people? And I think that line is different for everybody. So you do what's comfortable for you and know that it probably is going to shift over time. So what's comfortable for you now might not be what's comfortable for you in a month or in 6 months. And it may be that at some point you really need everyone around you in your circle to know, because you need their support and you need their help. And I will say that a couple of times I've had patients who very strictly didn't want to tell anyone in their community other than their family, and sometimes I have felt like they have been more isolated because of that. It's kind of this like elephant in the room that they know is there, but can't talk about. So, but that's a process, and I think just accept where you are now and know that it might change. And then how do you get support for family members? So this is back to Don and Lisa's talk, working through your cancer center or nonprofits in your area. There's often a lot of support available for family members, or through your church or through community groups. What we call the new normal. Often when you're newly diagnosed, it is a period of disbelief, and that's normal. There's a period of fear, of course. I mean, this is something that every human, if they've stopped to think about it, thinks about their mortality, but you've now been forced to think about it now. So it's a process, and it's a normal thing to have this fear and this disbelief initially. What can you do? You can set priorities and think about learning to live within new limitations. This applies to me, so I just had to put it in. It says I'm listing my deadlines by due date so I can miss them in chronological order. So I called it the new normal or just normal. If you're at my house, I think it's just normal. But it's good to recognize, like, we're human. You know, we have limitations. We are not endless beings, no matter where we are in our life. And then these are common decisions that many of you are making. I don't have the answers for you, but these are things that people are thinking about. Do I change my life? Do I keep working? Do I keep everything the same? Do I change things? Do I think like, okay, well, now bucket list time? Maybe it's a mixture of both. And I think that some soulful discussions between you and those closest to you about what your priorities are, what your life goals are, help you figure out what that balance is. And then planning for children. So certainly getting the help of a counselor with that, I think, is key. As Dawn was talking about, getting help with, the developmental age of your child. And then I put purposeful planning because I think about some of our patients over the years that have done wonderful projects, legacy projects, or I think Dawn was talking about a dignity project. What do I want people to remember about me? I mean, I'd like to do this myself for my daughter. What would I want her to know about me? I've had some patients write cards to their children for future events. Wedding day, maybe your child is 5. You write them a card for their wedding day. Why not? Graduations, future birthdays, as a way for you to feel like you're providing yourself in that moment and that you're thinking about them with real purpose. It brings some satisfaction, I think, to some of the women that I've worked with that have done these things. So being very purposeful in those things. And it doesn't have to be elaborate. I would encourage you to, I heard a suggestion about every time you think of something, scribble it on a piece of scrap paper no matter where you are, date it, stick it in a shoebox. And just keep doing that. Like every time you think of something, that's beautiful, right? Can you imagine? Gosh, I'd love to have that from a family member, picking out little scribbles of things that they wrote just to me. So there's an idea. I read it in a magazine. But that's purposeful. I mean, I like that idea because it doesn't require a lot of effort in a time where you're juggling a lot. You don't have a lot of energy. You're not gonna like make a scrapbook. Something simple is nice. So that's all of the content that I wanted to share with you because I really wanted to leave time if anybody has specific questions, general questions, thoughts that you wanted to share. Maybe we tickled some idea in the back of your brain. So feel free. I don't see any cards going up.
Several people today have mentioned metastatic being a first diagnosis.
Mm-hmm.
Is it possible to have breast cancer in other places before it's noticed in the breasts?
Yes.
Yes. Is it still in the breast? Like if you have breast cancer in your liver, is it still in the breast?
Yes. That's tough. That's tough even for your treatment team, right? So yes, so the question is, can there be metastatic breast cancer when you can't find anything in the breast? And the answer is yes. So sometimes it starts out in the underarm. So sometimes it can actually start in the lymph node. Sometimes it's so small that you can't find it on imaging. So we know that imaging isn't perfect. Like it's the best 2014 tool that we have. We have MRIs and mammograms and ultrasounds, but it's not perfect. Cancer is microscopic. It's something that we need a microscope to see, and it has to be a certain size before it can be seen on imaging. So yes, it can be microscopic, not visible on a picture in the breast, but still able to move outside that location to another part of the body. That's not that common, but it does happen. And boy, I think that's one of the hardest things to like accept, you know. It's
Yeah.
like, what? but yeah, that can happen. Oh, precious.
You have
That's a great question, and a complicated question.
I think I kind of understand the answer to it, but I just need a better way to explain it to other people when they ask me why I don't get a liver replacement.
Oh, interesting. So you tell people that breast cancer has spread to your liver, and they say, "Oh, just have a liver transplant." That's a great question. I think the answer to tell them is that even though it's in the liver, that's what we see on the picture. Metastatic breast cancer is really a systemic illness that we talked about. And so even if you did get a brand new liver, unfortunately, systemically, metastatic breast cancer would still be there. So the breast cancer would still be there in a microscopic way that we can't see on a scan. I don't know what I just did. Yeah, that's okay. We were done with that anyway. The other thing to tell them is that if you were to pause and have a liver transplant, I'm just throwing that out there, we don't do that, then it would take time away from therapy that we know works. And let's say you had a liver transplant with a long, prolonged recovery and you were too sick to take treatment, then we're really behind the 8 ball, right? So then we've gone after something that isn't going to change things in the long term and given up opportunities to give you therapies that work and can be quite effective. But that's a great question, and that's a hard one to answer. I have to say, I think that's the first time I've ever heard that.
Oh, really?
Yeah.
Yes, all the time.
Yeah. As a nurse in Alabama, I used to work with liver transplant patients. That's what I did. So I have some insight into that process, but I think that's the best answer. That's a tough one. Go ahead.
I am one of those people who do not have any scans that showed up positive, but I had cancer in my ovaries. So that was breast cancer. So after I got home from the hospital, I had this paper that said your mammogram is clear, see you next year. And they just did a hysterectomy, and it was everything, it was breast cancer. So my question for you is, I've met some people who were metastatic, and once they were able to achieve NED, the only place that they could find anything was in the breast with an MRI, and then at that point they gave them a mastectomy. So is that common to kind of like work backwards, I guess? Like you would go through treatment, try to achieve NED, and then would like really benefit you to have a mastectomy at that point, since those cells have already gone everywhere?
That's a good question too, and I'm glad that you brought up the term NED because I should have put that in the slide presentation. So,
It's my favorite term.
yes, this is everybody's favorite. Ours too. This is like high fives in the workroom. NED means no evidence of disease. So you do a scan and you can't see cancer, and you say, okay, they're NED, they're NED. Yeah, it's everybody's favorite word. We love it. Is it common to work backwards? I won't say it's common, only because it's not that common to present with metastatic disease as the initial diagnosis. But does it matter if it's common? Not really. Right. Doesn't really matter if it's common or not. So then the question is, if you're NED and there's still a tumor in the breast, should you do surgery to remove it? And that's a good question. There have been studies that have looked at this, and I have to admit that the data is not fresh on the tip of my mind, but I can tell you in clinical practice, many people would do surgery to remove that primary tumor, particularly, like we talked about, if there's only one site of disease somewhere distant in the body, sometimes, depending on how easy it is to remove it, we'll remove it. I would say that decision depends on a lot of patient factors. How well someone is, can they go through a surgery? How bothersome is this tumor? Is the tumor in the breast growing? that's a different question than a tumor in the breast that's just sitting there doing nothing quietly and it hasn't done anything for years. I do have a patient that I'm thinking of who has an intact breast tumor, who's had metastatic disease for a number of years. She's ER positive and has been on endocrine therapy. And her endocrine therapy is controlling the tumor in the breast. And so every now and then we say, like, well, if it grows, we could always do surgery, but it hasn't. So we don't. And she's not terribly interested. She's significantly older than you. So, but the answer is maybe. Yeah, maybe it is a good idea, particularly if it's the only site. If it's growing, then I think surgery or radiation to prevent it from becoming what we would say a local problem, prevent it from becoming painful or causing some kind of problem locally, then that does make sense. Yeah. Did I answer your question?
Yes.
There were multiple questions inside the question, I think.
I
don't
just
know if
know
I got them all.
that mastectomy wasn't an option,
It's
when
an
I was
option.
first diagnosed, because it was going to help the situation. But like I said, I just had met some people online who did achieve NED, and the only place that was left was with a breast, so that they had the mastectomy. So.
The question that your team will be asking is it going to change the long-term outcome?
Right.
Is it going to help you live better and longer? And it's probably different in every case, but I would, in some cases, clearly surgery is not the answer, but in some cases it might. And I think if your team thought it would help you live better and longer, then that's what they would and should consider. And that's where I wish I had this data off. Get my email and I can forward it to you, because there have been some studies, and Deb, chime in if you can remember better than I can, to look at whether removal of the primary tumor in somebody who has metastatic disease changes survival, what we would consider survival on a population level. Love that dog. So you're not a study and you're not a number, right? So I don't know how much that would be helpful to you, but I think if your team thinks it's wise and it's something you want to do, and it's okay to take a break off of systemic therapy. So that's always the other thing is, do you want to take a break off of your therapy in order to have surgery? Because there's surgery and recovery time, and all of that time you're probably off of systemic meds unless there's something sort of minimally bothersome, like hormone tamoxifen, those kinds of things. Boy, you guys packed the punch with the hard questions. What else? Those are good.
I was just wondering if, just in your own thoughts, have you identified any trends that you think resulted in better outcomes? Like people that juiced or people that had chihuahuas or things that patients did that just
Yes.
in your mind, it's not, evidence-based.
Yes, I would say exercise. Being as physically active as you're able has been, I would say, is a very consistent theme. I'm not talking about running marathons, but getting outdoors, walking every day, something like that. Maybe I would say people who are able to rely on those around them. So recognizing that we might need to ask for help in areas that we didn't need to ask for before. So taking some of the pressure off of ourselves to be the person that we were, or handle all the tasks that we did before, and sort of allowing that to give us space. Just giving people a little bit more resilience, because they're not feeling pressured to maintain 10, 20, we're all women, right? We know about overscheduling and overcommitting and multitasking, but creating maybe some space in your life, I think that And maybe what that is mindfulness, or that's what I was thinking of when I was talking about setting priorities and being intentional in how you spend your time. That practice, if you will, can be very calming for people. And so maybe it's the calming nature of that. I find people tend to do better. Your question was, what if people juice? The nutrition questions are frequent. Yeah, no, but it's good that you ask that, because a lot of people ask about nutrition, like, well, should I become a vegan? And recently this week, I'm probably the last person in America who has heard of this documentary. What's it called? I don't even want to say it because y'all are all going to go out and watch it. There's a documentary, it's about being a vegan, and somebody told me about it. I don't know that there's any data that if you're a vegan that you're going to live longer. But I would say, do what's in your power that makes you feel better, right? So if you feel good when you eat a certain way or do a certain thing, then that's probably the thing for you. If I had more time to think, I could probably come up with some more. Exercise may be the number one thing. It's a great question.
Could I volunteer something? This is just
Yeah.
a group that you can take it or leave it. There's a book called Anti-Cancer, and it's a very readable book. It's written by an MD, PhD, who was at Pittsburgh, and he had a brain tumor, had it removed, and then had a relapse. And then that's when he really got into, what else can I do? So it has a lot of nutrition recommendations, exercises certainly in there, meditation type thing. And you could read that perhaps and take some and leave others.
Mm-hmm. Yeah.
But it is very readable, and he has reasons for everything. Sometimes they're just studies on animals, on rats. This was very effective for these animals, and it hasn't been studied in humans. But if you're really wanting a full range of possibilities, now my wife is a total believer in this book. I just got partway through it so far, but I've been impressed. Specifically, one of the things was soy, and there's a great controversy about that. And this is just to back up the book's author. He says, well, the best study on that in people was in China, and those women were eating soy all their lives. So, can you apply it to someone who at whatever age comes in and starts eating soy? So he presents that there may be some limitations to these.
Thank you for that. There is one caveat, and this is Dr. Carey, who I work with. Always, it's a hard thing, right? So you want to feel powerful and empowered, and you want to change the things that you can, and you certainly want to do the things in your life that are good for you, like exercising and being mindful. What you don't want to do is feel that if you don't do it perfectly, that then if things don't go well, that it's because you didn't maintain the standard, whatever it is you've set for yourself. As an overachiever, I can totally see that, right? Like, we all can identify with that a little bit. So you have to take yourself out of the position of being responsible for what happens. You are responsible for how you cope with things and how you respond to what's happening, and how you're navigating this, but you're not responsible for the outcome. And certainly, I think if there was something in your lifestyle that we thought you could change, that would change the outcome, like, we would do it, we would all do it, and we would just close the cancer center down and go home, right? Like, and that would be done. But it's important to remember that these things are good, but they're only as good as when they make you feel better, right? So yes, I think all of, anything maybe in moderation, as long as we keep a good perspective.
I'll throw in one more thing if I may.
Mm-hmm.
This is a little amusing on my wife's, she's not here, not here. But she indeed, as I said, believes in this, and she did the all natural diet, so to speak, but especially these green vegetable type things. But she did that to such an extent that those all contain potassium. So after she had done that for a couple of months, our caregiver came back and said, your potassium levels are above normal. She just cut back to what is much more reasonable.
She was overachieving green vegetable eater. Yes, Popeye would be proud. It's a great example. Thank you for that. Did you have one more question?
I have some, so I guess my question would be, so if you had one word of advice for newly diagnosed people, what would it be? I know it's hard, I know I'm putting you on the spot, but
No, I'm just
you work
trying.
with so many.
One word of
Well,
advice?
I mean, yeah,
Gosh, I don't know.
one sentence.
There's so much, I don't know. I don't know that I have advice. I guess an observation is that we're all in our life journey, and we don't know what tomorrow holds for any of us. And this is the place we're at. So we didn't know we were going to be here. You didn't know you were going to be here. None of us know. Here we are, right? This is the journey, so we're gonna do our best to walk the path that we're on. And I guess that's my best advice. It's not really advice. It's more just an observation. And I think it goes back to what we were talking about before. Everybody faces this idea of their mortality, but when you have metastatic breast cancer, you're forced to face it, and you're forced to face it now, not on your own schedule or not later or not when it's comfortable, but right now when you're not ready. And I think just recognizing that this is the journey, and we're on it. We're on it now, whether we want to be here or not. So we have to kind of stick together, do the best that we can, be genuine with ourselves and those around us so that you can feel genuine in your life. I mean, hopefully that applies to everybody, but like we said, this puts it in your face. So I think in just recognizing that that's where you are. I don't know if that's what comes to my mind.
What should we expect at a monthly oncologist appointment?
Great question. So what do I expect at my monthly checkup when I go see my oncologist every month? Probably labs, maybe not every month, but I hear laughs. Maybe lots and lots of labs. Or every 5 minutes, or every time we think about it, or maybe we should have drawn more. But maybe not. Not everybody gets labs every month. Probably lab work. Definitely a conversation about how life is going, how treatment is going, anything new that you're noticing about yourself, how you feel, symptoms. And then I think, monthly visits, you're probably not going to rehash everything every time, but it's kind of a point to check in, see how things are going. Physical exam. So if you come in and say my back has been hurting for 2 weeks. I did lift that case of water, but I just want you to check it out. Kind of a focused physical exam based on how you're feeling and what your treatment is. And then a discussion about what you're going to do for the next month. So is this working? Do we need to tweak? Do we need to, maybe we need to change some things up? What are we going to do over the next month that was different? Or maybe it's just high five, everything's going awesome, let's not change a thing. Keep doing what you're doing, see you in a month. And then maybe often we talk about when should we do the next scans? Is it going to be a month from now? Is it going to be 2 months from now? Those kinds of things. Does that answer your question? Sort of the practical answer. Yeah, that's what most of our checkups look like. Deb?
Do you ever recommend or do you ever see patients taking treatment holidays?
Yes, we talked about that. We do, yeah, that's okay. We didn't talk a lot about it, and it's a good question. We do treatment holidays, or what we talked, when I said chemo holiday, we'll say. Sometimes a therapy is working, but you're just tired. You know, maybe you've had, I don't know how much of it, and you're just beat up and you need a break. And sometimes we'll call time out. Maybe it's for 2 weeks, maybe it's for a month, depending on how stable things are. Sometimes therapy holidays are longer. It depends really on the pace of the disease. So I think it's always an appropriate question if it's something that you want to think about. It's always appropriate to ask, and your oncologist and your team will tell you if they don't think it's a good idea now. You know, maybe they'll say, you know, not now. Let's kind of get over this hurdle and then let's think about it then. Or maybe you want to think about it. People do it. I think I mentioned the people have kids home from school in the summer or going on a vacation. I have a patient in 2 weeks going to Disney World, taking her entire family, and we've been sort of preparing. We've been sort of like getting everything ready. We're gonna take a little therapy holiday. I shouldn't say this because we're recording, but I'm gonna give her a few days of steroids, get her feeling really good. I mean, it's Disney World. So yes, I think well-timed therapy holidays are just the answer sometimes, right? Because back to that image of the runner, it's a marathon. We're pacing ourselves for this long journey, long run. We're not in the sprint. Yeah, so sometimes a holiday is just right. Yeah. I'm not keeping track of the time. Oh, okay. So don't let me hold you up. Thank you for being here. It's an honor to be with you, and enjoy the rest of the conference. Thank you.